I think before we go to our end discussion, we should hear Fabio Ingalina. Hello, Fabio. Look forward to hear you speak about rheology applied to the clinical practice and how to treat the nasolabial fold.
Hello, Per.
Hi, Fabio.
Always pleasure to be with all of you. So I'm going to analyze both the anatomy of the area and how to use the correct hyaluronic acid in different layers. Because always for me, anatomy is mandatory to understand the anatomy of a region before to inject and to choose the correct hyaluronic acid. So what is the nasolabial fold? For me, is the boundary between two different regions, anatomical regions, the cheek, the more medial portion of the cheek, and the perioral area. And in the cheek, especially, this area is characterized by the presence of the superficial and deep nasolabial fat compartment that don't lose volume during the aging process, as we are going to see. On the other side, we have the superior lip, the perioral region, with the superficial fat, the subdermic, subcutaneous fat, and the deep retroorbicularis oculi fat. What means aging process in this area? Surely, the nasolabial fold became deeper, but is the consequence of two different processes. A changement in the cheek, in which the loss of volume, both in the superficial fat, deep fat, in charge of the medial and medial cheek fat compartment, both deep and superficial, and the loss of volume in the medial SUF and into the deep medial cheek fat created an pseudoptosis process that create a more evident appearance of the lateral portion of the nasolabial fold. Surely there are patients really young with a really evident nasolabial fold, because we must always remember, as I'm going to show you, that is an anatomical structure with a septum dividing two different anatomical region of the face. On the other sides, in the superior lip and perioral region, the loss of volume in charge of the superficial fat, deep fat bone, create more depression, with the depression especially at the base of the nose and at the level of the ala of the nose, because of the retraction of the piriform area and the retraction of the deep fat and the reduction of the deep fat in contact with the bone. So clinically, we must be able to differentiate different level and difficulties in the treatment of the nasolabial fold. The first one, we have a light depression, no cutaneous marks. So it is a quite easy case, or not with really light indication in treatment, or really easy case. The second one, we have always not important depression, a moderate depression, but with a skin fracture. So the fracture in the skin is more evident and they require a different kind of treatment. The third one, the classical deep nasolabial fold, in which we have important depression, skin fracture, and cheek ptosis, and require always both treatment in the cheek area and in the cheekbone area and in the nasolabial fold area. I must confess that the nasolabial fold has been, and also today, is always the last area that I will treat in my patient. I am a surgeon, so patient come in my office to have a full face evaluation and treatment. So I begin always to treat the cheek before, and I will treat the nasolabial fold as my last treatment, my last step. And the last one is a really deep nasolabial fold with a big cheek with, in my opinion, no indication in the treatment, in medical treatment. She requires a more surgical she has a more surgical indication. So this really nice article wrote by Joseph in 1994 was one of the first that analyzed the nasolabial fold histologically and anatomically, and it was one of the first that correlated the nasolabial fold with the fibrotic ligamentous structure that fixed into the skin and reaching the bone and the muscular level, the muscular layer. So both the orbicularis oris muscle and the insertion of levator's muscle and zygomaticus muscle. And from these, today, we know that following all the studies performed by Pessa and Rory, that along the nasolabial fold, as I can show in my dissections, we have a septum going from the skin to the bone. As you can see here in this dissection, I injected before the nasolabial fold in red, I injected before the cheek in green. There is no migration just behind the skin because of the nasolabial septum that travel all along the fold. So superficial nasolabial fat compartment, superolateral upper lip fat compartment, as described by Pessa, and you see there is no migration. All the injections have been performed before the dissection. And same anatomy analyzing the deep fat compartment. Always the septum and injecting medially to the septum into the perioral region, deep in contact with the bone. And dissecting the levator labis superior and the levator labis superior lacunae muscle, we discovered deep in contact with the bone, the rhisto space. And you can see that my medial injection doesn't migrate laterally because of the septum. And believe me, I over-injected in cadaver this area, always to evaluate the real possibility to migrate of the hyaluronic acid. So deep injection and superficial injection medially to the fold maintain the area. There is no lateral migration because of this septum. So another important thing is always the evaluation of the vascularization to perform superficial or deep safe injection. This interesting article wrote in Plastic and Reconstructive Surgery Journal by a group of Korean plastic surgeons evaluate the relationship with the nasolabial fold and the facial artery. And we see that in 42%, 43% is traveled just medial to the nasolabial fold, in 23% just lateral, in 19% crossing from medially to lateral nasolabial fold, and in 15% from lateral to medial. So in the majority of our patients, the facial artery is there. The second question is which depth, how superficial is, and this really nice dissection article based on dissection of the area analyze the relationship between the facial artery and the muscle, the levator labis superior lacunae muscle, and zygomaticus muscle. And in this group of subjects, we must remember that in 54% of the dissection, the artery was superficial to the vessel. So it traveled in the subcutaneous fat. Surely the depth of the artery close to the commissure, to the oral commissure, is really more important than the depth of the facial artery or angular artery close to the hela. I found in some dissections the artery really subdermic or superficial, subcutaneous, close to the hela. So also the use of the needle in different areas has to be completely different. And the last thing is, this is one of my dissections in which I found a variation of the vascularization of the lip. As you can see, this is the normal vascularization, facial artery with the superior labial artery, as I described in my book, And second variation, second artery is a duplex facial artery here that travel more laterally. But you can see here at the level of the cheek and second superior labial artery traveling superficial in the nasolabial fat compartment and just under the dermis in a subcutaneous layer and reaching the upper portion of the lip, giving both the subhalar branch and columellar arteries going into the nose and the base of the nose. So in this kind of patient, it is quite risky. It's a variation, surely, but it's quite risky to use the needle in a subdermic layer. So injecting 2 or 3 millimeter deep and using the needle, a needle. So how to inject our patient and which product? Cannula superficial injection in this kind of patient is safe and quite easy and effective. In that one, both the depression and the fracture require the use of both cannula and needle. Cannula, superficial injection needle into the dermis. The last one requires the cheek treatment, deep injection using the cannula, superficial injection using the cannula, and last, superficial injection into the dermis or just subdermic to treat the fracture of the skin. And the last one, don't treat this kind of patient, it's more surgical. So which kind of technique? I prefer to go from downward when I treat only the lip, cannula, inferior entry point, vertical fan shape, or retrograde injection. I always treat the nasolabial fold and also the more medial portion of the perioral region to recreate a more fullness in the area. Subcutaneous fat, middle or high density HA. What means middle or high density? Surely in this kind of patient, you can also use a high density HA with a high G prime because of the quality of the skin, the tightness of the skin. So you can use less quantity of volume and use a more rigid product. In older patients with thin skin and thin subcutaneous fat, is more and middle density with a middle G prime hyaluronic acid because of the quality of the skin and the thickness, the really limited thickness of the subcutaneous fat. Cannula, 27 or 25 gauge cannula. Second one, patient in which always cannula superficial injection, needle deep dermic or just subdermic. It means 1 millimeter deep. You must feel your needle that cross the skin and maintain the subdermic layer. Microboluses along the nasolabial fold every 5 millimeters. And please don't inject more than 0.05 milliliter per point. So it's really a drop of hyaluronic acid. Otherwise, you can create Tyndall effect or irregularity, visible irregularity to the skin. Low density HA and 30 gauge needle. And the last one is superficial cannula and deep cannula injection, inferior entry point. The difference is that when you use the cannula superficially, is a more fan shape injection with a retrograde action or injection. Injecting deep is more boluses using always the cannula. You can use the needle as Dr. Salti showed you. I prefer the cannula, but sometimes I use also the needle, but are from 2 to 3 boluses at the base of the nose, just deep to the ala and more medially close to the columella, is to recreate the volume and project all the areas. And always use a 27 or 25 gauge cannula in relationship with the hyaluronic acid you use. And high G prime hyaluronic acid require mostly a 25 gauge cannula. If you use a moderate or not elevate G prime hyaluronic acid, you can also use a 27 G cannula. And only to finish it, always injection in the dermis using a 30 gauge needle and not more than 0.5. And only one patient to show you how you can recreate this kind of result, injecting deep and superficial, but always I cannot show you all the patient. This is the typical patient in which I inject before the cheek, the cheekbone area, and the nasolabial fold is the last of my step of my treatment. As you can see, I treated also the marionette line and the chin at the same time. So first step, cannula, deep injection and superficial injection. And third is needle injection using a more low-coercivity hyaluronic acid to the dermis. Thank you very much. And this is my website and my mail. If you need information about this kind of injection or about my book, you can write me. Thank you very much.
Thank you very much, Fabio. Wonderful description of the anatomy. Just have a question to you related to the facial artery variability. We frequently know and see the variability horizontally, but you also mentioned briefly the depth variability. And I've seen clinically very distally loops of the artery going up, very superficial, close to the skin. Do you see that on your dissection seldomly or commonly, like very distant?
Sorry, I have to move my computer. Yes, I saw in this section. Sorry, I saw in my dissection quite frequently how superficial is the facial artery when you dissect only the last portion of the nasolabial fold. The last means the superior triangle of the nasolabial fold close to the ala. Sometimes in some dissection, it is really, I cannot say subdermic because, you know, in all the cadaver, the subcutaneous fat became a little bit thinner in these areas, but I can consider it not deeper than 2 or 3 millimeters. So I use the needle frequently in the lower and middle third of the nasolabial fold. I don't use it in the upper third or close to the ala. Also because the fracture is more evident in the middle and lower third of the nasolabial fold. In the upper third is more a problem of volume. So I use more the cannula.
And then also when it comes to the facial artery, obviously we have the parts in the superior labial and inferior labial artery. Have you ever seen it pass very close to the commissure? I mean, I've never experienced the artery in the commissure, obviously, and how close do you see it in your dissections?
No, less than you image. It means that our injection really in the commissure, when you want to treat the lip, are less dangerous than we image. The problem is more the nasolabial fold. You must consider the first, the superior labial artery generally in that small area is deep. It travels in the majority of the case behind in that area, behind the orbicularis oris muscle. So if you treat the commissure just behind the skin, is quite safe. Second is the origin from the facial artery is generally from 7-8 millimeters to 1 centimeter lateral to the commissure. So it's for me safer to treat the commissure using a needle than to treat the nasolabial fold going deep. The real problem is close to the ala of the nose. The rest is exceptionally, when you find this kind of variation I showed in one of my dissection, exceptionally, yes, in that kind of variation, we have a second labial artery, and the problem could be for the nose. But also in this case, there is always a really thin layer of subcutaneous fat, 1 millimeter that cover the artery. It is never just behind the skin. So if the doctor is able to maintain the intradermic or just subdermic layer, is quite safe.